start? Okay. Good afternoon, everyone. Welcome back from lunch. I'll invite our session 3 speakers to come and sit at the panel, and we'll get them to speak. Do you guys need new glasses of water? I'll grab them for you, I'll change them. Thank you. All right, so I'd like to first invite Dr. Salim Chaloob, who will be discussing metabolic bariatric procedures and indications. Dr. Chaloob is an Adelaide-based surgeon trained in Australia who specialises in advanced laparoscopic, general, bariatric and metabolic surgery. With a fellowship from the Royal Australian College of Surgeons in 2011, he received additional training in laparoscopic gastrointestinal surgery in Brisbane and Sydney, and bariatric surgeon in Melbourne, Sydney and the USA. And he established a bariatric metabolic clinic over a decade ago, focusing on long-term patient care and contributing to the Bariatric Surgical Registry in Australia and New Zealand. Dr. Chaloob performs over 1,000 bariatric procedures annually. Please welcome Dr. Chaloob.
Thank you so much. I'll first to start with to thank the association for this fantastic day and very impressive and successful day with addressing the hot topic around the world. And many thanks for inviting me, Dr. Sheikh, for talk today. As I mentioned in my introduction, that I've been doing it over a decade now, and probably more than that, but we do have quite a big numbers of bariatric procedures being done in different part of Australia and New Zealand, something different from what we do here as well. We can start. Doesn't reflect here. Yeah. Oh. Yeah. Now, we've heard all the morning about medical and what sort of obesity and stress on the obese patients. We've heard a lot of talk about the cardiovascular, about the sleep apnea, about the respiratory stress, about the definition of the obesity, which, as you know, it's a chronic disease. Now, the term of a chronic disease is to differentiate from acute and chronic illness. The acute has got a reversible chances very good, and the chronic has got a settlement chances as longer term. In my a lot of first slides is just repeating of what others stated in earlier today, but I might just mention to you, globally we are covering around 1/3 of the population have suffered from obesity. And in Australia in particular, that's in 2019 when they looked at the adult, and you can see them more than 2/3 now, overweight and obese. The obesity itself is progressing, and the obesity itself is increasing and causing more comorbidities and becoming really a hot topic in every conference we go, in every subspecialties we talk about how we can manage these conditions and the consequence of it. And as you said, and as we mentioned, all the subspecialties mentioned, that it will hit every single system of your body. It will hit every single subspecialties and specialties and the GP's practice. It will hit everyday work. So diabetes is one of the most important for bariatric surgeons and physicians who deals with weight loss to address, but it's in fact more to it, and you've got to address other comorbidities, cardiovascular, atrial fibrillation, we spoke and we heard about it, and other injuries to our system. Definition of BMI is a number which one of the questions was earlier, how do you approach your patient? And you can't tell the patient you're obese. So what I suggest to the GPs is to take your patient and measure the BMI. So say, look, I just need to look at this BMI and I want to look at your weight, I want to look at your height. And then you sit down and say, oh, look, I've got a slides there, which you can put that. And I say, look, your BMI is just above what they're meant to be. And if you go above to that, then you're probably is going to end with a lot of issues with your liver, with your heart, with your lungs. And you start the conversation in a peaceful way, rather than to start with obese and you need to have a bit of weight control, because a lot of people don't look at it that way. They look at it what you want to address. So my position as a bariatric surgeon, I want to address the comorbidities. I want to address the atrial fibrillation. I want to address the cholesterol. I want to address the sleep apnea. I'm not just looking at weight. So it is important for me when I see them. Most of the time they come with their good referral, and the patient comes to me as a specialist. They know exactly what they have got on board and what we should go. In 2022, the guideline has changed, and mainly American-based. In Australia, we follow most of our obesity-related guidelines is American, and there is an International Federation of Obesity Surgery, which is mainly based in America and Europe as well. They have changed the BMI of indication or criteria to put patient under surgery above the 30. Now, we used to do 35 or plus, and usually diabetes the plus, but now is a 30 plus, and diabetes is to that. But anyone with BMI 35 and more, they are going to be offered a surgery after full multidisciplinary assessment. Asian, of course, it will be different, and we do see a lot of Asian, South Asians, and I look at a BMI 27, but the guideline saying BMI 25. And in adults, and a lot of referrals which comes from a different subspecialties, we have to look at them individually, regardless to the BMIs. Now, when I'm talking about other referrals, meaning subspecialties of the cardiology and orthopedics and abdominal wall hernias. I just lighted about the bottom line is for the children. We have got a centre in Adelaide, but it's not that expanded. We don't have a lot of people who involved in children. There is a big centre in Brisbane. There's a lot of Adelaide and South Australian goes there. In my practice, we go 17 plus, but I see quite a lot of 14 and 13 and 12 with a BMI above 40. And I do tell them you've got to wait. They do have a very complex multidisciplinary discussion before we go ahead and offer them surgery. It's greatly underutilised around the world, and particularly in Australia. So the public sector of weight loss procedures or bariatric in general is very poor, but the private sector is far better. There is a reason for that. The public hospitals, with the growing of the population, they're more busy with cancer and trauma. And a lot of elective surgery has been placed at the bottom of the list, and obesity unfortunately one of them. But in fact, the cancer, it has got a significant connection to obesity. So we've been trying to push the public sector to do more, but the public is just because of the funding and because of the availability of the beds and the staff, it has got a slight lower intake. I mean, I do nearly 1,000 procedures a year, but if you look at the public between the Queen Elizabeth and Royal Adelaide, they do 70 a year. And Flinders, as far as I know, that they stopped ages ago. But they used to do as well 50 to 70. So it's quite significant different from one surgeon who does 1,000 and many surgeons who are in the public hospitals in a massive place to do probably almost nothing compared to what we do. I have looked at all the access and the losing weight of the bariatric surgery. We've got a data to show you the national and the personal experience coming in the coming slides. But in general, we do know that a randomised controlled trial showed the bariatric surgery is a winner as in reducing the comorbidities. But having said that, in a 5-year randomised study, did show the combined medical and surgical approach is better. So we don't say just surgery and we don't say just medical. We should say together, and we should all work together. The idea is to treat the comorbidities. Diabetes, we heard about it. There is no cure, but there is a good remission. Which one is going to be a longer remission is in surgery. Which one is going to be shorter is medical, but which one is the best is the combined. So we do need to think about which patient is going to have those two approaches at the same time rather than having one and to compete each other. We're not competing at all. I never compete. I do like to work with the physicians, with the general practitioner as a multidisciplinary approach, is that because without them, it is hard to achieve. And all of the chronic disease is the same. I mean, even if you treat atrial fibrillation or you treat respiratory diseases or sleep apnea, you've got to be in contact with the specialties and subspecialties to make it really happening, and you get a success on that. So the workup on those complex scenarios has to have a really multidisciplinary approach. And the surgery is one of those who are going to be a tool to help all of these guys around us to make the outcome and the best outcome of it. So what I have to do is to coordinate all the multidisciplinary team to achieve the results for the patient. By the end of the day, my role is to show you what kind of surgery available and what kind of surgery we can get access to, and what kind of surgery has been approved Australia-wide and New Zealand, of course. On the other hand, I'll show you some investigational operations as well, which has been practiced in somewhere around Australia, but is not all of it in South Australia. And I personally later, and I will explain to you what I normally do, and my teams is going after me to talk about the medical therapy and the nutritional diet required. History in Australia, a while ago, we used to do a lot of lab bands, and lab band was the theme. So when I trained, one of the surgeons used to do 11 of them a day, and they used to compete about how long it's going to take, and one of them is retired in South Australia, used to do it in 20 minutes. The operation was very safe. You can reverse, you can remove the band at any time, but the issue is starting to show very slow in losing weight and has got a complexity of the foreign body inside, which may migrate inside the stomach and may migrate to the liver and it may migrate somewhere else around. We've seen ones removed in the chest, and I have removed personally 2 from the mouth, which is migrated inside the stomach. So I have done a research in 2007, presented in Hong Kong. It did show 40% complication rate. In general surgery, if your complication above 5%, you've got to have a peer review. So if the procedure showing 40%, you should abandon that. And that's what happened in Australia. So we got that out of the way. So there's only one surgeon in Tasmania does a band, but there is none else anywhere else. But as far as I know, that this guy is stopped as well. We progressed to a sleeve gastrectomy, and the idea of the sleeve it was in the whole history of bariatric for years and years, but we haven't heard about it. This was in American morbidly super obese with a BMI of 70s and 80s, and I have seen how they deal with that. When they used to do only gastric bypass, American used to push for that. It was so difficult and very complex to do it. So they started to do a sleeve, which is technically taking significant portion, 80% of the stomach to be removed, and that improved their weight loss over 12 months, and then they go and do the bypass on top of that, so their risk will be less when they lose 60 or 70 kilos. But then the study of them, which they have done it, showed that 30-40% or up to 50% of them did not require another operation. And hence the investigation started about the sleeve gastrectomy and say, well, where is that and how that happens? It's technically the ghrelin hormone, which is built around the curve of the stomach, which is going to be removed. And that's the lab band never touched that. In the sleeve it has. And that ghrelin hormone is responsible for the hunger. And that's why you've heard me when I said the stomach is an endocrine organ. The excretion of this hormone, it hasn't been removed on the sleeve gastrectomy, majority of it, 60 to 70% of it has been removed. Now, I don't tell my patient this is a restrictive procedure, because if you rely on that, there is a high risk of stretching it. But if you tell them this, your appetite is going to be changed, then you will explain to them in the way of a hormonal treatment rather than a portion treatment. This operation is safe and has got a good weight loss, but there are issues, of course, with it. It is irreversible, and I tell the patient, don't come here and tell me put it back, it's gone. But it can stretch and people regain weight. They do need to have an aggressive and good multidisciplinary follow-up of these procedures, because if you don't do it, they will regain weight very, very fast. But the good of that is in a sleeve is a good experience for a younger person who in their 20s or even of these 18s and up to 25, they can add a lot of multidisciplinary to it by losing the weight. Yes, they will have a bit of restriction, but the majority of it is related to the hormonal and less appetite. But these operations need to be looked at as a tool and don't give a cure to the patient. As we mentioned before as well, I normally tell them, look, it's a chronic disease. We're going to put remission to you. But the court is yours. You've got to be playing really well to keep it as long as you want. It's not just one person as a surgeon did the job and that's it. You've got to follow up. So we follow them up really intensively every 3 months for the first 2 years, and we do a blood test every 6 months. And then after that, I'll follow them. We see them once a year for life. And if you continue to be in touch with them, you will monitor the micronutritions as well, because you don't want to end with someone in emergency department with significant deficiencies. So you have to do your best to follow them up. The complications and issues with the sleeve is very, very small. And I tell you, the smokers, I had experience with them with their complications, and I don't operate on smokers. I tell them, go, stop smoking, come back, because I tell the patient, damage to you, damage to me, so don't cause damage to me. The reflux is multifactorial. It comes from reduce the pressure of the stomach, and it does come from a missing or structural problems in the sleeve itself, and sometimes is a higher or increase in the portion and faster eating, it can cause that. The gold standard operation around the world is the Roux-en-Y bypass, which is the full bypass. That's what the patient usually comes and say. Now, majority of my work is the bypass, and I do this sleeve as a second line. But the bypass is the idea of it. It used to, we didn't know exactly how that worked, of the Roux-en-Y bypass to start with, which is 80 years ago. And then it slowly evolved, and the one I was just in front of you, it's American way. So we do around 100 centimetre, 2 limbs separated, the blue and the yellow, and we reduce the portion of the food in the stomach. We bypass the majority of the proximal upper GI system, and then we get the combined food with the digestive enzyme distal to that. If you look at the concept of absorption of the fat and sugar, you will see that's coming from proximal part of your bowel. And any absorption of fatty nutritions or micronutrients comes from the proximal 2 meters of your bowel. So ideally, if you look at the concept is restrictive, yes, there is a small restrictive there, because instead of you having 2 liters of stomach, it's going to end with 50 to 100 mils. I tell them you can eat whatever you like to eat, but don't increase your carbohydrate and fat compared to a protein. You can have a protein 2/3 of your meals or even more, and you can have a taste of the carbohydrate. So I'm not stopping them from what they eat. They can eat it, but in a smaller portion. There's a lot of it is unwanted by the body, is going to be gone through, and that's the problem with the bypass, which is ending with dumping syndrome. And dumping syndrome is well recognised and in this operation, which in a way, when you look at it, I am happy to see, which is all my patient that comes to me and say, I had it once or 2 times and I will never do it again. Now, in a way, it is painful to the patient they're going through, but for me, I'll say, oh, good. Well, there is a bit of something to stop them from going back to that habit, and hopefully that's not going to happen. So we do see a lot of people who are relying on McDonald's or a KFC or a fast food. This operation is not going to be the best for them. So a lot of people, when they come to me and they researched and done a lot of research and come to me and say, I don't want the bypass, I want the sleeve, then I spend a lot of time with them, because these are the ones who are worried from dumping syndrome and they want to eat more carbohydrates and fatty meals. Now, that advantage of this operation is well recognised, has got a really above 70%, not just below, of excess weight loss. We've got a good resolution of the comorbidities, and we've got a really good outcome in terms of all the sleep apnea and cardiovascular issues. We do have a specific and general complications. It's a fiddly operation. You do need to do it with a team. We do them probably 10 a week of those, and I have been inherited a lot of revisional surgery who had a band and a sleeve before, so I have to change them to this operation. The complication usually comes from a bleeding in early stage, or infection, or abdominal pain in a later stage. That's the common things you see. There is a lot of dehydration. We deal with it every day, but that's easy to manage. There are some ulcerations which can happen at any time, particularly with the smokers, and there are dumping syndrome, which we have to deal with it. Surgeon has to be available, and of course, all my team, for treating these complications. There's a lot of them, they get stones in the gallbladder and we had to remove it. Percentage-wise is 10% or so. But in general, we're talking about a bypass in general, it's a best operation. Hence, there's a lot of issues for internal hernia and a problem with the technicality of the Roux-en-Y bypass. This operation came to the lines, and you've heard it a lot. It's a single loop, so it's not a lot of changing in the direction or rerouting the bowel. It's technically making a long sleeve of the stomach and then hooking up the small bowel to it. The bile is the green one. It goes up and joins the red, which is the food. That's the area of concern. The bile, when it comes close to the stomach, there will be a risk of ulcer and a risk of reflux. And that's why this operation is not my primary operation, but it is an operation you can offer it for someone who is significantly diabetic and they don't want to have a Roux-en-Y bypass. That's a good operation to offer rather than a sleeve, because it has got superior management or treating diabetes. It's a good operation if he's morbidly super obese. Those people, you can do a Roux-en-Y bypass, so you can do this operation 12 months later. You change it to a Roux-en-Y, much better than a sleeve itself. There is a better operations with the bypass when you go to move to the single anastomosis duodenal, but every time you go and bypass more small bowels, you need to worry about more micronutrition deficiencies. So this operation, if I do it, I will do it to someone who's got severe or uncontrolled diabetes, and the Roux-en-Y bypass may be not enough, and he's a super obese. I'm going to convert that patient to relying on vitamin D and calcium, because the absorption of those are going to be very poor in this surgery. So I have to be very selective if I go to this, but it's well recognised in Australia and New Zealand, and there are some people do it regular for revisional surgery. So if someone has a sleeve before, you can offer them this operation as well. The other operations I'm going to go through are investigationals, which is some surgeon did them in the past and regretted it because of complications, and some other surgeons are probably doing it for selective. I don't do biliopancreatic diversion. It is a comorbid procedure and has got a significant issues. In general practitioner and other subspecialties, they hear is a bypass, but you need to know what kind of bypass, because there are so many bypasses and different from one to the other. So this one is completely different from Roux-en-Y and has got a diversion of all of digestive enzyme all the way to terminal ileum. So technically they get fat malabsorption and they get malnutrition and a protein deficiency. So they do lose good weight for sure, but the reversal rate is very high to this operation. Balloon is the hot topic now. There's a lot of people like to put a balloon in the stomach. The balloon in the stomach, it should be designed for someone who's got a lower BMI and wants to lose 8 or 10 kilos of their weight. They should not think about a long term. There's no evidence behind it to support it. There is a cost on that. It will cost them $7,000 or so. I actually stopped doing the balloon for the last 5 years because of the evolving medical therapy. So if I put them on a medications which might cost them 10% of what they're going to pay to the balloon, they will achieve weight loss much better with less complication and less side effect. Balloon is good if I personally call it a wedding dress balloon. So if I see a girl who wants to lose 8 kilos or so and she's got 7,000 to throw it in the water, I say, yep, all right, we can do that. But ideally I introduce the medical therapy first and I get them out of the way. Where they did have a few complications. Now, it might be an investigational which will come at some stage in a better looking balloon. As in America now they do double balloons. And it still is going, and the data or the evidence behind it still need time to approve it and when we're going to be aiming to this. So I personally don't believe it's a good bariatric procedure. There are other procedures. One of them has been done in South Australia but then abandoned. This is called aspiration therapy or aspire. They're technically putting a tube in the stomach and they eat and finish their meal and then they go to the toilet and they open that tube to empty all the stomach. It has got significant issues and it's almost no one in Australia would do that today. There are some sleeve which done without resections. One of them is laparoscopic, and you go and you plicate the stomach without removing it. And another one is endoscopic. You go from the mouth and you plicate it from inside without removing it. Both of them has shown a smaller or less excess weight loss, but in the long term, it's a problem because you're going to distort the whole anatomy of the stomach. So if you go to another operation, it's very difficult. I revise, or I don't do them, but some other do, and I revise them from this operation to another operation. And I tell you, it's a very, very difficult to change them to another operation. So it's investigational. It might take a bit of time to get to the right way to do it, to minimise the risk of surgery. The endoscopic barrier, it's like a tube, and you throw it in a small bowel to avoid the absorption in the first part of the small bowel, as I said, in the first metre or so. And that has raised a lot of issues because it causes bowel obstruction as well. Again, it's not commonly practiced everywhere. Revisional surgery, so that is something which is increased with time. Over the last 5-10 years, we've been seeing a lot of people who's going from one operation to the other. The success rate, it depends on the technique, the person who is going to do it, and the success rate of that, it depends on the multidisciplinary approach and how to change the habit of this person who already been through an operation beforehand. So most of the time, if you do a revisional surgery, you've got to have it all and you've got to do it the best, because you will be the best outcome for the patient in the long term if you give them better operation. Most of the operation will be converted to the Roux-en-Y gastric bypass. These are the evidence, these are the data across Australia. We've got a Bariatric Surgery Registry. So this registry is established in 2012. And I was first of the committee who established this registry around Australia and New Zealand. I was a supervisor on this committee till now in some of the hospitals, and we review all of the data and what's submitted. It's around 160,000 has been done so far, and it's probably more over the last 8 months or so, because it will be updated in September. The outcome of it is quite good, which I will give you an impression about it. But revisional surgery has increased, which meaning going to a second operation. We have done, as my team and I, we've done a quite good number from all of this 160,000, and still we are contributing a lot. If you look at it, how the Australia-wide, we do the sleeve more than any other operation, but the bypass, it's rising, and if you see the yellow, it's increasing. We used to do only bypass and bands. Now we do a sleeve and a bypass more. It has got a good outcome from comorbidities, particularly the diabetes and the heart disease. And we do reduce the mortality or premature death by 30 to 50%, and that's evidently on that research. If you look at the 12 months outcome for post-surgery as a remission to the diabetes, we've had 80% of the patient on remission from one non-insulin therapy. We've got 73% on one non-insulin therapy prior to surgery. And 50% of them, of the patient got both insulin and none. And then we have a 70% no longer on that medication. And how rewarding when you see a patient comes to you with diabetes before and a lot of medications, and 12 months later, nothing left there. But I still let them know that it is a remission and it can come back at any time, and we have to stick to the rules of the follow-up. In general, a sleeve, it has got a good body weight loss over the years, but the bypass is slightly better. In terms of the long term, the bypass is longer to stay compared to a sleeve. And I do tell my patient a sleeve, it may take you 5 to 10 years, but a bypass take you even double than that. In my practice, we've got a multidisciplinary approach. We are patient-focused and controlled, and we do it in a way that make it safe. And the safest things I've found is to liaise with the subspecialists who already see these patients and to get a communication with the GPs. A big team, always, if you have them all on board, they will help you a lot. I've got an intensivist and an anaesthetist who works with me really very close, and most of the time we are discussing cases constantly, even when we operate on every day. And we do operate 3 to 4 days a week, and the outcome of it is actually the happy day for all the team, and you see them excited about patient comes with no medication on board after losing the excess weight, and particularly the obesity in general in Australia is rising, and we are trying to handle that. Before we go to the next speaker, I've got a video. You can stop that one and start video. I'll just show you how we operate in theatre. The video is a long video. I don't want you to see it all, but I'll just show you the first 5 minutes if I could. The monitoring of the heart and the respiratory, and my anaesthetist who is facing Alistair Walker there, he put all the monitors facing me as well, and we've got a very good exposure to inside, and we have got a very good safe and operation when we have a team who's monitoring everything. You can see me now, I'm focusing at what I am going to do, putting a local anaesthetic to block the path of my putting the ports through, and just to give them more pain relief. But everybody has got a job, and Alistair at the back there, he's monitoring and giving the anaesthetic at the front, and he's got his own monitor as well. The things I wanted, if I speed up, which is the next of it, you will see the monitoring of the equipment as well. All the equipment will be opened as disposable, and it will be opened by the request of the surgeons. Assistant has got the job to target the site of surgery, and I'm lucky, honestly. My assistant is Dr. Wicks. She's my wife and mother of my children and best friend, and she is the bariatric practitioner and see them before and during and after. And that made my successes much better because they see the same face all the time. Most of the patients you get referred, they're very anxious about the operation. 99% of the cases they will go to a laparoscopic. Open surgery is very, very small percentage, unless it's a planned. But the team who works with you, if they answer, you can see the nurse. I never ask her what I want to, but she knows what I am because she's been working with me for long. And all my team, there are 3 teams now, and they work with me all constantly, even in different hospitals. I get the setup of the team. And if the team works with you, you will do it safe and well. If the team has got no understanding to what you do, it will become really hard and difficult, and the complication rate will be higher. In our cohort of nearly 4,500 of patients, we haven't got any death, which is good to hear. We did have a lot of people who had dumping, and we have to talk with them about it and correct that. I did have 3 leaks. They are smokers, and in older days, and I did tell them to stop smoking. And now, if I any smokers, I stop them and I say, don't come to me. And even the anaesthetist and the practitioner, when they see them, they tell them, do not bother, because he doesn't want to damage. And I don't want to see them if they are. I did have a couple of bleedings, which I had to go back and fix it, but that's again a while ago. Didn't have really major issues to worry about, but I'm always available to them. Now it comes to just this next minute to show you how the accuracy of the equipment and how many people checking it before I finish that video. Ideally now what I'm doing is just to mobilise the stomach, which is the organ of concern in bariatric surgery. And we need just to make it smaller, so to create a little pocket of stomach rather than a 2-litre size of a stomach. This usually needs a stapler, and the stapler size is usually decided by the surgeon when you have a really good feel inside and you see the and you know what kind of size you're asking for. It is expensive process, as you see, everything disposable. It will cost money if they're not privately covered, but a lot of people are using superannuation, and I'm probably more than 30% of what I do, they're using the super or self-funding. Most of the time when you open equipment, that's it, it's thrown in the bin. So most of the equipment now has been opened, has been used. There is a little screen at the side that's recording the operation. I record all of my operations and I keep them in my office. I always go back to them if there's anything happens or anything wrong. You can see me now, I found a tumour in the stomach there, and that shouldn't be there. So I decided to remove that tumour at the same time. Luckily, this case, it did come a precancerous and has been removed in the same operation. So we're just not doing operation for the weight loss, but we do operation to fix other stuff. Sometimes you find incidental hernias, incidental hiatus, incidental stomach in the chest, or incidental tumour, which you have to take that responsibility. You're not going to wake up the patient and say, what do you want me to do with that? It is important to go by principle. The principle is different from place to place, but the schools is one. We do go to aim to have a reduction in the volume or portion of the stomach and reducing the comorbidities. Now there is a request from me to the nurse to start preparing the stapler. The stapler is going to be the size I have decided once I go through, and now in the next few seconds I just want to show you that how we check it, because there is a lot of checking process happening in theatre for an operation. Gastric bypass takes me an hour to do. A sleeve gastrectomy is around 30 minutes. But they are different from one to the other. We do deal with a lot of weight issues. If the patient above 200 kilos, you'll be treated in Calvary, Adelaide. Very supportive. Calvary, North Adelaide is major operator space for me to operate, and I do them, or most of them in Calvary, North Adelaide. Calvary in general very supportive to bariatric surgery, and they always been. There's a lot of mentors who operate in these hospitals before and achieved a really good outcome. The anaesthetic team, I don't change them at all because they know exactly what I'm doing as well. There are certain tubes which need in the size or portion or driving skills of the anaesthetist and the safety of the operation. As I mentioned before, its safety proven is the best operation, and even we're comparing ourselves with the gallbladder surgery and appendix surgery because the risk is less than 1%. So that's the last bit here. So the equipment opened. This is the stapler, and the nurse taking it is going to be looked at by checking it. There's only music behind for my music, and that's why the nurse is a bit shaky. The staple has been placed in there, and you will see confirmed by another nurse, and then once she confirms it, and you can see them, they are working behind me because they've been trained to do that, and they do them. That video is particularly taken to make sure to tell the patient everything been checked. There is nothing has been missed in there, and then once checked it and put it up. Now we're going to open the cartilage, and that's the size I requested and been checked with the expiry and the manufacturer. And then once we put it together, these are all disposable. You put it together, you line it up, and you make sure it's working, and then you get a third person to check it and it's all working as well in order, and then that will be passed to me. And we'll carry on. Thank you so much for listening, and please don't hesitate to ask. Thank you.
Thank you so much, Dr. Chaloob, for your very insightful and interesting presentation. We're now going to invite Dr. Jessica Weeks to come and speak to us about pre- and post-operative management. Dr. Weeks is a bariatric medical practitioner, GP and surgical assistant. She obtained her fellowship with the Royal Australasian College of General Practitioners and furthered her training with a fellowship of Advanced Rural General Practice, Surgical. Dr. Weeks has advanced her expertise in obesity management with accreditation from the World Obesity Federation SCOPE program. Please welcome Dr. Weeks.
Thank you. Obesity is internationally recognised as a chronic disease. It's not changing. Green?
Yeah, that's good.
There we go, beautiful. Obesity is associated with a low-grade chronic inflammatory state and immune dysfunction. It is suspected that this long-term chronic prolonged state of inflammation leads to the disruption of homeostatic mechanisms and consequently to metabolic disorders commonly associated with obesity. These are mediated through multiple different pathways, but particularly with the upregulation of cytokines, hormones, and acute phase reactants. The morbidity of obesity is related to the increased fat tissue and the effects that has on the health. Metabolic complications of excess fat are influenced by the amount of fat deposited, particularly around the central abdominal area, which is your visceral fat. Obesity is defined using BMI, and whilst this is an easily reproducible marker, it's not the only thing that you should consider when looking into metabolic disease and treatment. There's now becoming more subclassification of obesity phenotypes and the effect of that on the body. And that's particularly when we saw the earlier presentations in terms of lower BMIs, but actually having metabolic complications associated with it. So there's multiple factors associated with obesity, and I think this is one of the really big things that from a GP and from a bariatric medical practitioner side is it's a really nice thing to actually explain it to your GP, to your patients. It's not just about diet and exercise. There's actually multiple different areas that come into it: genetics, psychosocial, social side to it as well, environmental, behavioural, and particularly now neurohormonal that we know about. And the neurohormonal particularly comes from that altered physiological state where long-term the body upregulates what is its now weight set point and will fight vigorously to maintain that weight. So once you've been overweight for a particular amount of time, so overweight and obese patients, it is no longer as simple as diet and exercise. And in fact, really large studies, and the biggest primary care study in the US, looked at patients over about a 9-year period and looked at the amount of people in a strict diet exercise program that actually managed to maintain 5% weight loss. And of that, within the first year, less than 1 in 8 men and 1 in 7 women were actually able to get the weight loss off, and then certainly to reach a BMI of 25. So these were obese and overweight patients. To reach a BMI of 25, it was less than 1 in 210 men and 1 in 125 women. And then by that 9-year mark, you can see that the amount of people that maintained that significantly dropped off. There's lots of studies into genetics, and they're a bit older now in terms of twin-to-twin studies. But when they looked at children that had been adopted out, it was found that those children tended to follow the BMIs of their genetic parents rather than their adoptive. So whilst environmental certainly plays a role in it, it's certainly not the only answer to it. They also had twin-to-twin studies where one was diet and one was overfed, and they seemed to keep a very similar BMI long-term as well, and particularly after the study. So the interesting thing, and this is one of the really big targets, both in surgical and medical side in terms of obesity, is looking at that brain-gut axis and the effect of the neurohormonal on that. So there's 2 major areas, the hypothalamus and the mesolimbic system, that they target. Now, there's lots of hormones, you've heard all about them, particularly one of them is ghrelin. Ghrelin's produced by parietal cells in the fundus of the stomach. That's one of the major targets in both a Roux-en-Y gastric bypass as well as in a sleeve gastrectomy. And then there's some of our other hormones like the GLP-1 and the GIP hormones, which are some of our newer obesity-related medications as well. Complications of obesity, you've heard about it all well and truly, but it does contribute to more than 40 major disease categories. It's certainly a leading cause of premature death and morbidity. It has a significant contribution to a number of cancers that's well recognised now, cardiovascular, diabetes, as well as renal disease as well. But pretty much it's a multi-system, affects everything. The benefits of weight loss, you've already heard a lot about it as well. 5% weight loss can have a significant benefit. However, by the time we get to 20% of total body weight loss, we're starting, in obese patients, we're starting to see really, really good benefits from that. There's lots of medications that contribute to obesity. So when a patient comes in to us, one of the things is we will look at their medications. However, I have great respect for everybody that refers to us, and one of the things we'll do is talk to the patient about what medications they were on, why they're on that medication, perhaps if they tried other medications in the past. Now, I won't go and actively change anybody off medication, but we will then liaise with the primary prescriber and see if there's a medication that would better benefit. You know your patients very well, and prescribers know why they're starting on different things. But just in general, there are certain groups of medications that we would prefer patients on, or if you are starting people on medications within the limits of PBS guidelines for some of them, then there's certainly some that are a little bit better than the other. Sertraline is one of our, in terms of an antidepressant, one that seems to be most weight neutral. Paroxetine tends to be one of our ones that really tend to put on weight quite a bit, and mirtazapine as well. Ideally, if we can choose any drugs that we want in terms of diabetes, going down metformin, your GLP-1s or your SGLT2s tend to be much better in terms of your weight. and trying to avoid your sulfonylureas, your insulin as well. So there's lots of different agents for obesity management. What is approved and what is available is another thing altogether. So in terms of criteria of what we're looking at when we're putting patients onto medication, a BMI above 27 with a comorbidity or a BMI above 30 with no other comorbidities. I think it's important to recognise, as Dr. Chaloob said, once they get to a BMI of 30, we really need to make sure, and regardless of who I see, I still let them know the whole kind of cascade of the different options available for obesity and how they all work together. And I would bring up surgical as a very early thing in the discussion, even if and not as a recommendation necessary, but even if the patient is to be made aware of it. Because one of the things will happen is with medication, if they have suboptimal weight loss or they have weight regain, they can get a little bit upset if you've never given them the other options along the way. So orlistat, phentermine, liraglutide in the form of Saxenda, and semaglutide in terms of Wegovy are approved in Australia, but Wegovy's never been available. Off-label, we've got topramate, tirzepatide, which is got some availability now. Semaglutide, again, off-label, and Trulicity if you really want to. So what do we look at when patients come in? So one of the main things we'd look at is what are their concerns? From us, it's much easier to bring up being overweight and obese because that's why they've come to see us. In terms of if I was in my normal general GP practice, again, it's probably a little bit easier because patients would know that that was my interest, but other doctors will put up a sign of, are you concerned about your weight? I'm happy to discuss it. And that might be just an easy way to open things up to patients without directly bringing it to them. But patients that have got, obviously fit the BMI criteria for it. Some patients, I think, that do well in terms of medications are those with the lower BMIs. Look at the weight of where they normally sit because they might present to you after actually having some dietary intervention already. So don't necessarily exclude patients purely because they actually have dropped their BMI a bit, but be a bit sensible with it as well. But patients with a lower BMI never really had a concern of their weight. Something's happened, maybe a different medication started or something, a crisis in their life, who knows, something's happened, they put on a bit of weight and they just need some help to get it back off. As a multiple approach to obesity, so some patients will come in well over the 200 kilos. I think a very low calorie diet in those situations tends to do very well with a lot of intensive work with the multidisciplinary team, but they would be ones as well. Those that need some help with some weight maintenance or to get them back on track if they've got some weight regain as well. It's really important to look at their weight history, how they've gained weight, what the different things have happened, dietary and lifestyle modifications, which has to work all in conjunction with it. A lot of patients will come in and they don't eat regularly, they tend to skip meals, they have larger portion catch up meals, they're then very hungry and they'll go to that higher caloric, easy, quick food. So it's trying to modify all of that. So I never start patients on medications, or very, very rarely, without dietary input prior and some dietary changes. They tend to just get disappointed in the medications if they don't have that dietary background already underway. So my dietitian is, my husband's my best friend, my dietitian's my second best friend. Exercise as well, psychologists, really linking in with the multidisciplinary that they already have in place. So if they're already under a psychologist, other subspecialists, and obviously there's a specialist GP using you as well into it. Adjust medications where possible. So if they are on some of those medications that make them put on weight and there's another option, then discussing that with their primary prescriber as to whether that could be adjusted. It's important to closely monitor for side effects. I do get the patients to come back. Initially, I see them, I'll provide them with written information all about it. I get baseline blood tests for them, get them to see the dietitian. They'll come back, have a discussion. We'll talk about what works best for them in terms of the medication. There's now phenotypes associated and some evidence behind that. So somebody that is constantly hungry and doesn't really have any satiety and is constantly looking for food will do potentially better with a GLP-1. Somebody that is a bit more of an emotional driven in terms of eating, there's some benefits in terms of contrave, and then slow burners in terms of Duramine. But they tend to all more overlap a bit, so it's more trying to find what's right for your patient based on side effects and things like that. But monitor them when you do start them, see them at 2 weeks, 4 weeks, and really every 4 weeks ideally. Keep them seeing the dietitian as well. The longer you can get them to follow up, the better they end up doing and keeping their weight off as well. But remember that I'll show you going ahead, there's a lot of patients that actually don't respond to the medication, so there's no point keeping them on it after that 16-week mark if they really haven't lost 5% of their total body weight. So one of the earlier ones is Orlistat. I can honestly say I've never prescribed Orlistat. Orlistat's a really older drug. Most patients don't have very high fat dietary intakes. That I certainly tell everybody about it, but it stops about 30% of absorption of fat. What you tend to get is if somebody is eating a lot of high fat foods, they end up with really quite terrible diarrhea, oily diarrhea, and it becomes quite non-functional in terms of work and things like that. Sandoz trial does have a reduction in your HbA1c, and there's about 4 kilos loss or so in the first 12 months. But like all these medications, there tends to be some regain as you continue on with it, although it's one of our cheaper ones as well available. Phentermine, it's TGA approved, it's not on the PBS, it's a sympathomimetic, so it increases the release of noradrenaline in the hypothalamus, which then suppresses appetite and therefore energy intake with the subsequent weight loss associated with it. It's about 3.6 to 4.5 kilos lost in some randomised controlled trials. The doses range from 15, 30 and 40. If you're going to start your patient on it, just be mindful that obviously anyone with quite severe cardiac disease, valvular disease, anyone with ischemic heart disease, arrhythmias, don't start them on it. Be quite cautious in terms of patients with psychiatric illness, anxiety as well, or drug and alcohol addiction. There can be a slight addictive component to it that you need to be mindful of. Seizures as well, just steer clear of. All of these have flags on them in terms of pregnancy, and they haven't been well studied in terms of breastfeeding, so they tend to be contraindicated on the evidence base that's available. Make sure you monitor them. Same thing, at least 3 monthly. They're only being approved for 3 months in Australia, and then you're meant to bring them off. But there are some larger studies in America. They would keep them on for at least 2 years. They've also have a combination drug with it as well. Duramine, I think, is about $150 or so for those higher doses a month, and it's an oral tablet as well. Contrave is a combination of naltrexone and buprenorphine, so they both work synergistically on both the hypothalamic hunger system and on the mesolimbic system as well. So they increase the firing of the PONC neurons, and then they have associated appetite suppression and a negative feedback as well, which then works more. They're approved for 18 to 65-year-olds. They work by reducing cravings and by improving early satiety with it as well. Dosing is dosed up over 4 weeks. With all these medications, dosed to where the patient gets the best outcome in terms of weight loss, so where they're losing weight, appetite suppressed, cravings suppressed, and they have the least amount of side effects. So you don't need to go to the highest dose. Go slowly. You don't have to dose escalate as quick as what they would suggest as well. So you start off with 1 in the morning in the first week, 1 in the morning, 1 at night in the second week, 2 in the morning, 1 at night in the third week, on to 2 in the morning and 2 at night as well. You can't use it for patients with... The company themselves that make this do have very good prescription pads in terms of prescriber prescription pads, easily to follow and everything like that. They've got a list of all your medications you can't use with it. Just be mindful in severe renal and hepatic disease. They can slightly increase blood pressure as well, so you need to monitor that. Because it does have naltrexone with it, just be conscious of patients with opioids on board. I would avoid it in those patients. And the other thing, it reduces seizure threshold. So somebody with a head injury, known seizures in the past, or a current seizure disorder, be mindful of. I'm reserved, and I'm very honest with patients that really require their license for their income to prescribe this. So truck drivers, I would be a little bit more reluctant to prescribe Contrave, or bus drivers, anybody like that. If you have a seizure, automatically it's a loss of license for that 3 months, and then so on from there. The main side effects patients get: headaches, dry mouth, nausea, constipation, and majority of this is all dealt with reducing portion sizes, and this is why they need to see the dietitian. They're not going to be able to do the catch-up meals, so regular small meals, good protein intake as well. Saxenda is readily available, and it's probably this and Contrave have been the ones that we tend to not have had any issues in terms of supply. It's TGA approved for obesity, but it's not on the PBS. It's a GLP-1 receptor agonist, as are majority of the next ones we're going to talk about. It works on both the PONC neurons in the hypothalamus, so it induces early satiety, but it also has some external CNS effects as well. So basically it delays gastric emptying, they feel fuller longer, and the appetite reduces as well. About 36% are non-responders to that. About 50% of patients can tolerate it, so you need to go slowly with it. There's a couple of different studies, or there's many different studies done on it, but the companies will say about 5 to 8% weight loss in the first year. They tend to have some weight regain by the third year on it as well. So I think it's really important to sit down with your patients and actually tell them how much that works out to be in terms of their current weight, because some patients will think they're going to lose 40 kilos based on it. Biggest side effects: nausea, vomiting, reflux, in which case you really need to tell them, drop down your food size, make sure you're getting your regular meals in, increase your hydration as well, and take it slowly. Always warn them with any of these GLP agonists that you can get pancreatitis. So if you get severe epigastric pain, nausea, vomiting, you feel very unwell, they do actually need to present and make sure they have lipase checked in. And realistically, it's, you can have very mild pancreatitis, or you can die from pancreatitis. The other thing is thyroid tumours. You do need to warn them that in rats, and there has been a patient case study, but there's a lot of variable factors there as well. You can't use it in pregnancy, multiple endocrine neoplastic syndromes, or in patients with a history of pancreatitis. It's preloaded in a pen, so it's much easier for people to use. You dial it up by 0.6 per week, and it's a daily injection, which patients need to be aware of. There is a Saxenda Care program with it as well. Semaglutide is the same at 2.4 milligrams, is called Wegovy. At 1 milligram or less, it's the Ozempic. Wegovy has been approved, we've just never got access to it. Tirzepatide is now a bit more available. So it was approved by the TGA in November last year for the use in diabetics, but it never went on to the PBS because at 5 milligram dosage, it has similar HbA1c reduction compared to Ozempic. So people thought it would be more available, but it actually hasn't been. It kind of became unavailable as soon as it was approved. It's not approved for weight loss. It is off-label here. However, in end of November, FDA approved, and in the UK, they use it for weight loss as well. It's approved in pre-filled syringes. It's not made in a pre-filled syringe. If you have a good pharmacist and that you can work really closely with, you can actually prescribe it reasonably well. They just need to be able to, basically, it's like a vaccine vial. You can't use a multi-device on it, so it's a 1 vial per injection. It's a weekly injection. It's more expensive, so they start off at about $315 per month for the first lot of dosages. You start on 2.5 weekly for 4 weeks, then you can go on to 5 milligrams and subsequently go up to 15 milligrams, which is $645 per month. Maintenance doses, which is really what they've studied, is at 5 milligrams, 10 milligrams and 15 milligrams, but they need to have some dexterity. They need to be able to kind of safely draw it up with a needle, change needles, inject and dispose of that as well. It's our first dual agonist, so it's a GLP-1. The Cement trial shows at 5 milligrams, it had up to 15% total body weight loss. 10 milligrams had 19, and 15 milligrams was up around 20, which is really big numbers compared to what we've had in the past. Interestingly, in the Surpass trials, which was a head-to-head in terms of Ozempic at 1 milligram, comparing it to tirzepatide at 5 milligrams, 10 milligrams, and 15 milligrams. This was in a population of, the mean weight was 104. The BMI had to be over 25. They had to be over 18, type 2 diabetes with HbA1c of 7 or more, between 7 to 10, and they were already on 1,500 of metformin. They looked at it over 40 weeks, and compared to the SMONT trial, the weight loss was much more modest in this group that was very intensely followed. So whilst those numbers look very good, it'll be interesting to see how it actually plays out in the actual normal population. So they were much smaller, 7.6, 9.3 and 11.2. In terms of HbA1c reduction, I've already touched base on that, but that was the main focus of that trial. Topramate's off-label. It's not very well tolerated here. So in the Australian studies, 45% couldn't tolerate it at all. I find patients that have tried it tend to have reduced concentration and attention, and they feel really foggy and really don't tend to tolerate it very well at all. It's a very cheap drug available as well. But so a quick rundown of all the medications, which you can have a look at after. So why do people stop medication? In all honesty, cost tends to be the biggest thing, and I think patients not really achieving what they thought they would achieve in terms of weight loss. I'm extremely honest right up front about the risk, about the amount of weight, what it actually breaks down based on those percentages. The risk of weight regain, even if you stay on it, the risk of weight regain when you come off it. The side effects, I think if you see them at 2 weeks, 4 weeks, and kind of each month, and you include your dietitian, you tend to get through those side effects side of things. People sometimes achieve their weight loss and come off it, but I always say to them, this might be something you need to come on and off over time. Others will have had enough of it, and they'll be saying, I want to progress to bariatric surgery. Lots of people have now had access to it. They've got friends with it. They've seen the results. They've seen that managing their diet post-bariatric surgery tends to keep their weight off, and they lose a lot more weight as well. Follow-up is really important. It's a multidisciplinary team, so looking at a whole heap of things: micronutrients, weight, medication adjustments of what they've had prior to surgery, body composition, make sure they don't have muscle wasting. So there's really big focus on protein. There's nothing that you're not allowed to have, but we do aim for protein as your priority, which essentially by the time they get enough protein in, they don't really fit too many carbs in as well. Following up with all of their team, so make sure we're very strong on following up with the GP straight after surgery and ongoing, so that they can be involved in all of this as well. The rehab specialist works with us very closely as well for our patients, psychologist and dietitian, and our lovely surgeon. Adeline will touch on this in terms of micronutrients, but it's incredibly, if patients stay on their proper bariatric prescribed multivitamins, so BN or Fit for Me, they stay on their iron supplements. Obviously, we monitor their ferritin with that as well, but we're trying to aim for a ferritin sitting around that 70 to 80, not just your standard 15, 30. So we do get them on regular iron supplements and a calcium vitamin D as well. Some patients will need, and a lot of patients will come in with B12 and vitamin D deficiency, so we tend to really replace those prior. Intramuscular injections we tend to go to with the B12, especially with the stomach resection, R factor is released and it doesn't bind the intrinsic factor then, and so you don't get B12 oral absorption quite as well. It's also one of those ones you really don't want a B12 deficiency, so we tend to replace with intramuscular. Vitamin A deficiencies, A, D, A, E and K, really only seen in patients that stop taking their proper bariatric multivitamin. Same with folate. If anyone is a drinker, then we keep them on thiamine. We get them to stop drinking before surgery, but if there's any relapse in behaviour or we're concerned, we'll keep them on thiamine as well. Long term, we try and avoid anti-inflammatories as much as possible. If they absolutely need it, just make sure they got a PPI cover around at the same time. Avoid your oral bisphosphonates. We don't want ulceration of those pouches. Anything gassy forming, well, they won't tolerate very well. It fills up their pouch very quickly, so try and avoid it. In terms of antidepressants, the body seems to self-adjust a bit after 12 months. Just watch closely with it. But regular reviews, those with a very narrow therapeutic index need to be monitored closely, like your lithium, make sure they don't get dehydrated, your warfarins, digoxin, things like that. If weight plateaus, the biggest thing is make sure they come back. So dietary intervention, some will start to relapse. They really start to not watch their protein intake. A lot of it can actually be corrected when we get them back on track in terms of that. Addressing psychological and social factors, changes of medication they might have been started on that will adjust as well, looking at other medical potential issues, making sure they see the surgeon as well, so making sure some of the revisions, and Dr. Chaloob's touched on this, there'll be an anatomical variation that can be addressed, and that's why Dr. Chaloob is the master of revisions of Australia. The other thing is then we potentially look at the medications post-weight loss. There's not much evidence about using medications post-weight loss. There's many trials that have been registered with the Australian New Zealand Clinical Trials Registry. Most of them have been removed. Most are either recruiting or have been struck off for some reason. There's small numbers of patients, pretty high bias associated with it as well. Phentermine and topramate, there's some concerns around it. It's not to say you can't use them, but just the evidence is not quite there yet. The only big study that they did do was a retrospective study, and it was very mixed. So basically that entire list of medications, patients had been on a variety of those medications over the time, but it basically showed if patients' weight plateaued and you gave them some weight loss medications with dietary intervention, they probably lost a bit more weight. Patients that had regained didn't tend to lose as much weight with it as well. So it just reinforces it's really a multidisciplinary approach you need to take. Thank you.
Thank you so much for that comprehensive presentation. I'd now like to invite up Dr. Adeline Wong, who will be discussing pre- and post-operative nutrition. Adeline Wong is the founder of Nutri for Life and an accredited practicing dietitian, aiming to help individuals lead healthy lifestyles while enjoying their favourite foods. With over a decade of experience in primary healthcare, transitioning from a community pharmacist to roles as a dietitian and nutritionist, she prioritises open and honest communication. Adeline creates a non-judgmental, fun and safe space for her clients, likening herself to a GPS, guiding them through lifestyle changes and suggesting checkpoints along their journey. Please welcome Adeline.
Thank you for the invite for the presentations. So we have heard a lot today about how can we support the patients, and we know that obesity is a very complex journey. And I just want to share today a little bit more about what is the actual patients going through. We know how we will need to help them, what sort of support that they can go through, but what does the patients need to do, what is involved, what is the challenges that they need to go through in preparation for the bariatric surgery. So just a topic for discussion today, just a journey for the pre-operative nutrition assessment, and then what is involved before the surgery with a very low calorie diet that they need to go through, which is a huge challenge for them as well. And also after the surgery, there will be like a newborn baby journey. They have to go through the new textural changes, and that's another challenge that they have to go through. And also what is the most common complaint post-surgery that nutrition-wise or nutrition intervention can support them, and also some of the micronutrient supplementation that we recommended them to use. Just a summary of the nutrition journey that the patients will go through. So if they are going for the bariatric surgery with our team, they will have initial dietitian support assessment, and at least 2 or 3 more review appointments if required before the surgery. And once they have the surgery, they will have a first post-op nutrition assessment just to make sure that the hydration status goes really well. And then after that will be every 3 months or every 6 monthly, or at least annually after the first 2 or 3 years later. So during the initial assessment, it's a very intensive session for the patient. So it will be quite similar to how you feel right now, can be quite tiring. So for the patients, I will spend a lot of time for the initial assessment. Firstly, we need to double check and see whether they understand what sort of surgery that they need to go through. Obviously, they have a great discussion with Dr. Chaloob or Dr. Jessica Wicks already, and also give them some idea what is involved with the nutrition management. and getting a very thorough history of medical history, medications, and all supplement they are taking, which we have heard today, a lot of health conditions or other medication use that they're using can impacting on their weight management, and some of the supplementations that they may consider is a natural form and is not listed as medication. Sometimes they may not enclose to all the medical team, so I will have to dig deeper. What are they actually taking? They might buy online, herbal supplement, combination stuff, or even some energy drinks or Baroccas and everything before they go in for the surgery. So there's a very extensive discussion about what are they actually taking and any history of weight loss medication they have used before, any side effects and everything. The other part is I actually spent a lot of time gather more information about their social history and what support system they have. This is a lifestyle changing journey. It's not just a weight loss journey. So what support they have at home? Are they single parents? What sort of work they do? Are they a shift worker, truck driver? How many kids they have? Any appointments they need to attend with the kids that require special support? So they can be a very hectic lifestyle, and all of those can absolutely impacting on their nutrition consumption and also their energy level to prepare a meal, and also their decision making. When you're feeling tired, we always probably go for a quick and easy meal. So that can be a very challenging process. It's no right or wrong, it's just that this is a lifestyle that we all individual have. But then going through the bariatric surgery, we do need to have a set routine as well. So identify those situations and challenges so that I can have an idea, then we can put more strategy in place. Mental health, which we have heard a lot today as well regarding mental health assessments or any history of eating disorder or any medication that they're using. What is their challenge? Are they a binge eater, the grazer, or any history of bulimia or anorexia nervosa, any possible trigger factor that can impact on them when they go through this intense journey. And if they did have those history, what sort of treatment they have get before, or do they need more support? And that's where we will discuss as a team, and then we refer them appropriately before we decided to go for the surgery as well. And any nutrition-related symptoms, such as like IBS, they may have a lot of gut problem. IBD or celiac disease, they need to be gluten-free diet. How can they manage them, especially during the pre-op preparations? And do they come with a lot of issue with the reflux already, which they can also impact on how well they're managing their nutrition consumption. It's quite common now that people can also have a lot of issue with food intolerance, especially they have IBS or allergies. And also neurodiverse food issue. So for patients that will have ADHD, autism, they may have their own preference of texture, and they have also a very set amount of food they will like or they dislike, or certain food that can gag them, they will never ever want to put into their mouth. Sometimes can make it quite challenging for their nutrition management. So gathering all those information, understand them as individual so that we can actually plan to make the journey a lot more manageable for them, rather than this is it, you have to do it no matter how you say you can't do it, you still have to do it. And their weight history. So what is their heaviest weight, lowest weight, when was that? What is the event that can impacting on their weight fluctuations or medications use or stress? Or during COVID sessions, people can put on a lot of weight, emotional comfort eating, and a lot of things can trigger the weight fluctuate. So that's why gathering thorough information is there so that we can identify what is the actual challenges, what is the same trigger factor. And if we are living in the weight fluctuation ourselves, we may not be able to identify what is the problem. But if we go through that and discuss that with them, then they'll be like, oh yeah, I was really depressed during that time. And then, oh yes, COVID, I was eating a lot because I got no social lives and everything. So these are the things that can trigger that they might be a little bit more emotional comfort eating. And then if it's more severe, then we can refer them appropriately to get support for managing their eating behavior or eating pattern. And quite often that our eating behavior has been developed when we are young, culturally. I'm sure we all been told we have to finish everything's on the plate. You know, you got no dessert, or you can't leave the table, or you can be quite wasting with the food. So all these things can impact our eating behavior as well. And also, what is their goal weight? Do they have a goal weight, or do they feel what sort of weight they feel much more comfortable physically? And also the mobility will be improved. So these are the things we will discuss. And with their pathologies, before the surgery, we will have a very intensive first baseline monitoring and do the blood tests and everything. And of course, if there's any nutrition deficiency, we'll correct them before the surgery. And then we will get into their dietary eating pattern. So are they a meal, like skip meal, regular meal, or they're a large eater? Are they a binge eater? What sort of food choices? A lot of them also depending on their own preference of food, their work, their lifestyles. And sometimes people may have to prepare 2 or 3 different meals for the dinner due to the kids' preference, the husband preference, or the wife preference. So cooking can be quite a big chore and they don't like it. It's like, I can't do this anymore. So they can also impacting on their decision making with the food. And their exercise history. A lot of time people do love doing physical exercise routine, but unfortunately with the extra weight they're carrying, it can impacting on their mobility and also quite painful. And quite often, a lot of the patients, they do play a lot of sport, but then because of the extra weight gain, they're not able to enjoy those exercise routine anymore. So identify those what drive them to want to be more active, or something that they'll enjoy. These are the things that we can future also support them and encouraging them to participate, going back to the physical exercise routine. The other thing is also, people might find it weird when I ask them, are you chewing okay? Or do you wear dentures? Do you have any problem eating or chewing or swallowing? Because these do impact on what is their food decision making as well. So if they got issue chewing or if they got issue with swallowing, or choking, these are the things that we need to further investigate or just kind of like find the right texture food for them to consume. We would talk about a little bit of a weight regain possibility as well with this whole journey of the weight management. As we're all aware, weight fluctuate, you can lose the weight, you can regain the weight as well. So letting them know if they do regain the weight, it's not a failure, because they are very harsh critic on themselves. If they lose the weight, it's a huge investment. And then if they regain the weight, they feel like, oh, I failed the team, I failed you. They can be quite depressing. So just need to let them know that we're always there. It's like they don't have to go it by themselves. They can come back, we can review and assess so that we can put them back on place, put them back on the journey. And then lastly is understanding their why. Why do they want to go for a weight loss journey? Why do they want to go for the surgeries and everything? That's the intrinsic motivations that we always look into. And many people going for the weight loss journey is not just losing the number on the scale, it's about aiming for the best quality of life that they want to, and what is the potential that they can achieve in the best life. So understanding that and supporting them achieving that goal one little bit at a time, it definitely will help them to get through this journey a bit easier as well. Before the surgery, we do put them on a very low-calorie diet, and the reason why we do that is not just to piss them off, is to actually to help them help to reduce the liver size. Obviously, when they reduce the liver size, it will absolutely help with the surgical team, easy for us to perform the surgery successfully and also safely as well. So usually the range of the pre-op preparation is ranging from 2 to 4 weeks. So at least 2 weeks before the surgery, the very low-calorie diet does shows that it can reduce the liver size up to 25%. And if you do another additional week, it can reduce up to another 2.4%. So we do recommend that to use it for a longer term for patients that are high on the BMI. And it's a very low calorie, ranging from around 600 calorie to 800 calorie, sometimes could be up to 1,000 calorie, depending on individuals, but the carbohydrate content will be very low. It's kind of like less than 100 grams, or sometimes can be less than 70 or 50 grams. That will help them to keep their satiety and they can keep it a bit fuller as well. Don't feel as hungry. So when they start the pre-op preparation, the first 3 days is their challenge. I will tell them that the first 3 days, you may go through a big challenge. You may go hangry, very hungry, angry, frustrations, mood fluctuating. They can be also got headache, lack of concentration, because it's just how the body is getting into the ketosis process. If they get through the first 3 days with enough support, hydrations, enough food for them to get through, then they will get into the ketosis process, and then all those hunger sensation will reduce. They feel much more fuller, energy levels get better as well. And the most common side effects from the fast weight loss and ketosis, the most common one is headache, irritability, postural hypotensions and fatigue, and sometimes the bowel variations with consistency as well. So they will receive a very extensive list of what they can and what they can't. We do use a few preference of the products that we use, which is a VLCD range with the supplemented to manage the food intake. So it can be a few different brands that I've listed there and some other brands as well, according to their own preference of texture, taste, and also cost as well. Or some of them, they may need to consider their food intolerance. Some products could be having some more lactose, or some may not be gluten-free and everything. So there's at least a few options. So as a general, they usually use 3 products that will be equals to their 3 meals, breakfast, lunch, and dinner. And then there will be a long list of the vegetables and salad that they can have, which is unlimited. And in addition to that, I usually give them a little bit more extra protein, like from your meat, your fish, your eggs, just to get through the hunger sensation and to meet their protein requirement. So this is just a little bit more extra information for them. But when we go through the VLCD program, there's a few things that we need to be mindful of when we put them on, especially when a few medications or they're diabetes patients or hypertension patient. Patients that are on warfarin, digoxin, or lithium, we just need to be very closely monitoring them, as we all know that like warfarin can be fluctuated according to like a high vitamin K rich food intake. So when they're on a very low calorie diet, they will be on utilizing a lot more on the non-starchy vegetables and salad to bulk the meals up. So the consistency of the vitamin K intake can be varied. So we just need to remind them that they have to keep the amount of the dark green vegetables quite similar, not to fluctuate too much of the amount on there, so that it's not going to impacting on their warfarin management. And obviously with the digoxin medications, it's a very narrow therapeutic intake medication. When they start losing weight, it may also impacting on the effects and the levels of the digoxins. So we just need to mention and remind them about the possible signs and symptoms of the toxicity. And that if they do have those symptoms, we absolutely need to get medical advice. But as you can see, some of the toxicity symptoms can be nausea and diarrhea, which they may also experience during the pre-op preparations already. Lithium medications, hydration is the key important thing. So when they go through the pre-op preparation, it's also a fat burning process, ketosis process. It can dehydrate the body very quickly. If they don't drink enough liquid, and if they're on lithium medication, they're going to increase the risk of toxicity as well. So we keep pushing for the fluid, and also refer to the medical team or the specialist to keep continuing to monitor those medications levels. For patients that with type 1 diabetes, this could be a bit tricky because the VLCD program, as I mentioned, is a very low carbohydrate intake. So obviously they are super high risk of like hypoglycemia because it's a severe reduction of the carbohydrate intake. So the first thing is before they do anything, they have to have a very thorough discussion with the GP or the endocrinologist about their carbs and insulin ratio, what they need to do, adjustments and everything. And also they may need to also review the dose of the insulin used, usually depending on what sort of insulin they use. They may need to reduce by like 50% if they're long acting or the NovaRapid according to the carb ratios as well. We don't start them straight away using three products all in one go. I usually use a step-up approach. Start with one product, review and see how the insulin dose, how the sugar level, and then gradually ease them into it to reduce the risk of the hypoglycemia. But obviously with type 1 diabetes, they still need to use their insulin. We do not stop the insulin at all. Type 2 diabetes patients, similarly, if they are on insulin medication, it will be quite similar to the type 1 diabetes management. But if they're on sulfonylurea, definitely need to review and see whether we need to manage and reduce the dose and have a discussion and send them back to the doctors to discuss as well. And continue to monitor their sugar level to prevent the hypoglycemia. Patients on hypertension medications, if they're on multiple hypertension medication, encouraging them to continue to monitor their your blood pressure, because once they go into the rapid weight loss, in the improving their weight, like when we know that if we lose 5% of the body weight, which sometimes they can achieve with the pre-op preparation to start with, they can also improve their blood pressure. So sometimes medication could be a bit too high dose for them. If they constantly have a lot of lightheaded and dizziness, then I would definitely ask them to check the blood pressure and go back to the doctors and review their medications as well. After the surgery, the first 2 weeks after the surgery, the key important goal is to make sure they are very well hydrated having adequate nutrition and protein intake to support their recovery and also preserve their lean muscle mass and eventually gradually back into the normal texture food intake. So that's why I refer this as a little baby journey that need to go through. So on the day after the surgery, on the day of the surgery, after the surgery, there'll be a new bath meal. The first day one post-surgery, they'll be starting on 50 ml per hour of the water intake, starting to learn how to learn and engaging with the new stomach size. As Dr. Chaloob has shown you, it's a very small stomach that they have. We can't just have a shot glass to drink the water all in one go. That can upset and then they can trigger the pain and discomfort. So the first day in the hospital, they learn how to sip, very small sip. So it works out to be 1 little teaspoon sip every 5 minutes kind of schedule, just learning how does it feels like engaging with the new tummy size that they have. And then day 2 post-surgery, we go into like a clear liquid in the hospital, and then once everything goes really well, they go to the normal fluid, full fluid diet. Will be 2 weeks when they get home. So the transition will be 2 weeks of the liquid diet, 2 weeks puree diet, 2 weeks of the soft diet, and then eventually we'll get to the normal texture food. Now, I'm not sure whether you guys have done any liquid diet or puree diet or soft diet when you're in adulthood. Sometimes can be very challenging with the texture, even though when you're looking at the food can be quite challenging, especially when you're looking at the puree already. So we're not baby anymore, but they still have to go through the baby journey. So it can be very texture deprived, and visually, mentally can be also very challenging while they still need to go through the recovery journey. So what we want to aim for the texture progression is about healing, recovery, adjustment, and learning to the new normal. So the first 2 weeks is like slowly sipping on the liquid, getting all the thin liquids in, but good nutrition content for the recovery. We want to aim for at least 1.5 liters of the liquid in a day. It's very hard for the first week for them to do it because they still got inflammation from the wounds and everything. They only can have a small little sip. But we're going to persist with that to reduce any risk of dehydrations and also avoid constipation. It's a small baby step, but the key important thing is when the liquid diet is need to have the variety. If I ask you to drink the same liquid for 14 days, I'm sure you'll get sick of it by one day. So giving them a lot of variety, savory liquid, sweet liquid, some texture, some different temperature, it does helps them to get through a bit easier and feel a bit normal for themselves as well. And then the second part is the puree diet. This is a challenging part due to the texture visually. If I ask you, can you eat a puree bowl of bolognese sauce? Visually will be like not looking the best, texture-wise not best as well, but they have to do it for 2 weeks. So it can be very challenging. So we need to learn and make the food a little bit more enjoyable, a little bit more acceptable, and how to replate them is quite important. But they have to learn to re-establish the understanding about what is their portion with small teaspoon, small bowl, and small cup, so that they don't overeat. The portion that they can tolerate will be like close to about half a cup portion only, but they have to eat it very slow. They have to use at least a good 15 to 20 minutes to eat a meal. So it's not 5 seconds. So the food will get cold, especially during winter time. And then at the soft diet, there will be a lot more appetizing, a lot more manageable with the food intake, but the food has to be really soft and moist. But we have to remind them, you have to cut them into a very small bite size. It's like when you're first feeding your baby with the solid food, that kind of portion. They can't use a big tablespoon, they can't use the normal spoons and everything, because we still eat with our eyes. We always can overeat and quite a big portion. They have to be constantly chewing the food. That's why I ask them, is your chewing any problem? Do you have any dentures and everything as well? So throughout this whole process, hydration, supplementation, protein intake is carried through the journey, but it's just different in the texture. They will have a lot of resources. We do have I've recorded a lot of videos, a lot of emails. We got the apps and everything as well. They can always refer back to it because it can be quite overwhelming every time they attend an appointment. They can't retain a lot of information. So all the resources they will receive, they can send me an email, any problems and everything as well. And the most common complaint after the surgery, which we will be watching and monitoring all the time, is nausea, vomiting, dehydration, variation with the bowel consistency, reflux, dumping syndrome, Reducing the appetite, obviously, when we remove the size and the ghrelin productions and everything as well. Taste change is one of the most common one too, and the abdominal pain. So all these side effects, whenever it happens, we just need to review is it because of the food intake that they're eating, the texture of the food, how they eat the food, whether any of those problems that triggers the issue that are listed there. If nutrition intervention does not resolve any of those problems, they need to be referred back to the medical team to review and see any possible like structure or leaking or obstructions or anything. We need to minimize that from happening as well. If the patients are constantly vomiting every single day for a long period of time, we have to mindful about the thiamine depletion. So we do start them on the thiamine supplement as well. So looking at this picture, this is how you feel when you walk into some pharmacy or supermarket. So there's a lot of supplements. There's so many range out there now that I can also get very confused as well. So the three big range of the multivitamin that I classify them into, one is the gummy multivitamin, has become very popular right now. And the other type will be the generic tablet or capsule multivitamin, which you can get from the pharmacy or the supermarket. And the third one will be the bariatric surgery range multivitamin that we recommended to use. So according to the ASMBS guideline, which is the American Society of Metabolic and Bariatric Surgery guideline, this is the supplementations that we want to aim for bariatric surgery patients. This is the level that we want to aim for. At least this is the minimum amount that we want to achieve. And when we look at, and this presentation was presented by one of the New Zealand dietitians at last year NMOS conference, that they're looking into the gummy multivitamin in the supermarket. So most of the multivitamin supplementation gummy one, that they don't have B12, vitamin A, iron, and calcium and copper inside. They may have some thiamine, vitamin D, zinc, and folate, but they may not be sufficient enough compared to the recommendation from the ASMBS guideline. And from the report, from the American Society report also, the highest risk of deficiency after bariatric surgery, including all of the supplements, the highest risk like your vitamin A, your iron, your calcium, your copper, your B12. So if the patients are taking those lollies, gummies, they may not be meeting all the nutrition requirement, and the nutrition deficiency will be quite high. The other type will be the generic multivitamin, which is like, so for example, like your Centrums, your Nature Zone, the pharmacy brands. There's a lot of brands out there. Different companies have their own combinations of formulation. Some nutrients can be quite high, some nutrients can be quite low, so it may not meet the nutrition requirement for the bariatric surgery patient. So for example, like, let's say if they go for Barocca, there's more like no fat soluble vitamins in there, no iron, no calcium, no copper, and it can absolutely causing a high risk of nutrition deficiency. And sometimes they also can be quite high in vitamin C, and too much of the vitamin C sometimes can also increase the risk of kidney stone. So the bariatric surgery multivitamin, there's a lot of different brands, but in Australia, we've got the Fit For Me and also the BN multivitamin, which they have been designed to meet the nutrition requirement with the guideline that they wanted, which you can see it meets quite a lot of the nutrition requirement there. So I just list down some pros and cons with the bariatric surgery multivitamin versus the generic multivitamin. So the pros of the bariatric surgery multivitamin is like they're more in confidence level that we know it will meet the nutrition we require, the minimum nutrition requirement, and also can also lower the risk of nutrition deficiency, but it can also reduce the likelihood of toxicity as well with over-supplemented. And the cons is maybe it's a bit too expensive, but not always the case when you look at how many supplements that they need to take other than normal multivitamin. And also the accessibility will be usually more online. But the normal, generic multivitamin that you can easily get from pharmacy or supermarket usually can be quite heavily discounted as well. But the cons is sometimes you have to take so many tablets. It could be up to like 5 to 7 or 8 tablets in a day just to meet their nutrition requirement, which can be also quite expensive, work out to be, and also increasing the risk of toxicity, such as the B6 vitamins toxicity. So these are the range of the bariatric surgery multivitamin that we recommended the patients to use, and they got a really good support team online for the patients as well, and they can be continuously offer educational support as well. So the summary is, it's a journey for the patient. It's not a 30-day challenge. It's not a 12 weeks program. It's a lifestyle journey that we are supporting them through. And there's a very strong thorough MDT team assessment to support them for this management is crucial. And the dietitian role is not just about what they eat, it's also supporting them, educating them, and also advocate for them or refer them appropriately to the medical team. And the significant and ongoing GI symptoms are not normal. We just need to really investigate instead of like letting the patients know that, oh, I can't do anything about it. And also micronutrition deficiency can occur at all stages. So that's why we're constantly monitoring, checking in, what are they taking, and also monitoring through the blood test and treating them accordingly as well. Thank you.
In the interest of time, we won't be having the debate and discussion between Dr. Salim and Dr. Jessica, and we'll be moving on to the panel discussion. So we open up the floor for questions and ask that you raise your hand and we'll come around with the mic. Thank you.
Thanks for the talks. My question to the panel is that if someone is already on ketogenic drug, for example, ketogenic promoting drug, and you subject him to a very low calorie diet, what's your approach? For example, someone is taking Ozempic or some other form of drug, how you approach that? Thank you.
Hello. Yeah. So if they're already on the Ozempic medication, usually this is what my experience is, they're already not eating enough. So I need to get them eat more. Because it's like, a lot of the time when they are suppressing their appetites and everything, they're not eating at all, or they might just eating one very small meal, and that's the problem. They're not eating enough. So that's why a small frequent meal, we still want to go for slightly good protein content, but we still can have small amount of the carbohydrate intake as well, according to their own tolerance level, and whether they have any side effect when they're on those medication that causing like nausea or vomiting or reflux. So usually I'll get them a bit more smaller frequent meal to get them on that. But I'm pretty sure that before any bariatric surgery, we'll be stopping those medications as well.
Yeah, so this is why I always include the dietitian. So if we're purely doing it as in terms of medication only, not bariatric surgery leading into, then we just make sure if it's being used in conjunction in terms of diabetes, so any of your sulfonylureas, Ozempic, anything where it potentially affects your blood sugars in the background as well, then we make sure that they're regularly monitoring and that they're adjusted prior to that. In terms of in the lead, exactly what Adeline said, part of the issue in a lot of these patients, whether on those medications or not, is they tend to skip meals and then try to do a catch-up meal, which they won't be able to tolerate. It also means that when you come off these medications, if you're using them as a weight loss agent, they tend to regain really rapidly. So we try and get them into regular, good meal pattern, good protein intake. If they fill up on protein, they're well hydrated, they tend to reduce their carbohydrate intake anyway. In terms of surgery, there's some, and Dr. Chaloob would say this, there's some good evidence of aspiration. So we do like to get them off at least 2 to 3 weeks prior to surgery. If they're using it from a diabetic approach from that, then we obviously have to adjust that in terms of their other medication involved. And pagliflozin as well, we'll have to bring off 3 days prior to surgery. So some patients, and then insulin we half the night before, they all have to be adjusted in terms of the preoperative diet because their sugar's reduced down as well. So there is a lot of background work that we do with the patients pre-op, and they'll know really specifically what they need to be on. And we prefer to run them just that slight bit higher the night before surgery rather than have a hypo, but they do check. We also operate on them first thing in the morning and we get them in straight away so that we can monitor sugars and adjust.
Can I ask? Thank you. My name is Radwan. I'm one of the GP in Manapara. I used to work in Sydney before. I just have 3 questions, but very quick as well. Very, very quick, promise. The first question, a lot of patients used to come to me in Sydney, ask me to sign the form in order to obtain their money from the superannuation. And one of the points in that form says that this operation is life-saving. In order to get the money from superannuation, in order to get the money from the super, you have to prove that this procedure is a life-saving procedure. And I used to have a discussion with patients about how life-saving this life-saving procedure is. In order to sign it, and then what happened later on, the pediatric surgeon in that particular area, he used to fill the form for me and just to sign it. So don't discuss anything with patient. This all the boxes being ticked and signed. So I just would like to ask you about that form to obtain the money from the superannuation to justify the procedure. The second question I would like to ask...
May I just answer that one before you go?
I just want to say...
Oh, you want to ask?
Just quick 3 things and I will leave you. The second thing is one patient in my career, just one patient, in my feedback, one lady, only one lady came to me once, said to me, she feels much more depressed after the procedure, despite was successful procedure, as compared to the before the procedure. And I asked her, what's the case? She said to me, I feel psychologically, I have the weight, but physically I don't have the weight. I feel still tempted to eat. So psychologically, physically it did the job, but psychologically it didn't. And the last question, I promise you, this about how often patients come to us usually as a GP, say, please, I want to check all my vitamins again. Can I just check again and again, say vitamin A, vitamin B, vitamin C, B12, B6, B7, and as you might know, our computer sometimes doesn't show B1 and B6, it shows B12 only. So I just want to technicality from the GP point of view, I'm not trying to, thank you so much.
Oh, thank you. These are very valid questions, and I think these are questions of every day, and I get it in a letter sometimes from GPs. In terms of super, be assured obesity is a life-threatening condition, and definitely there can be a drop dead if you don't support them. The superannuation will be supporting any medically indicated. There is one patient who was in a paper 4 years ago in Sydney, which the GP refused to sign, and he ended with a stroke in emergency department, and he was suing the GP because he refused to sign, and he did win the case of 1.6 million to compensate. So I take that responsibility, and every surgeon and every physician in the bariatric field, they would take that. So you can easily, and I assure you, you can sign it, and then no one is going to negotiate. Having said that, you do need to go by the guideline because you've got a Medicare they're going to review. So you can't sign it for someone who's got a BMI 27 or 28 or 30 with no comorbidities. But if they have got a diabetes and you believe it's a visceral diabetes related to that, you can argue the case later when you get audited why you've signed it. And you can easily say the comorbidity is related to that. But if the BMI 35 or plus, no, you don't need to worry a lot. You can just sign it and move on. And there's no issues with that. If there's any issues, I'm happy to be approached at any of those. And I hope that answer to your first. Second is depression after surgery. Yeah, we do see that. There are a lot of patients that's been worked out very rapidly to bariatric surgery without identification or without clear explanation of the surgery and the aim of it with a multidisciplinary approach. For me, if I see my patient, from the time I see the patient to the time of surgery, it will be 3 to 4 months. The idea is not just because I'm busy and I've got a lot to do. No, I want that patient to be ready. And I always, when I see them first, they say, oh, I want to have my operation. I said, yeah, when you're ready. And my readiness is having bariatric practitioner reviewed, having the subspecialties involved in the past and to assess particularly the mental health situation, having the dietitian be on board. And sometimes I get a letter from a cardiologist or from a dietitian back after the assessment to say, no, this person is not ready, need another 6 months to work. So ideally, if you take them very fast to surgery, you will end with that problem. Patients need to understand the portion is important, the quality is important, and before they go to, it's a hard work for surgery, but the success is there. And I always tell them, you will work 3 or 4 or maybe 10 times more to lose your weight with that surgery compared to no surgery. So you always give them the hardest scenario before you offer them the surgery, and you'll see their response, because their response is important to open the discussion. I do see them a few times before surgery. It is inappropriate if you see them once or no, and straight away you rely on surgery is going to fix it. If you consider the surgery is a Mr. Fix-It, that's a failure and that's the outcome of it. But if you consider the surgery as a tool, it's going to improve the quality of life, then they will success. But the time is critical. In your third one, the follow-up, we've got a system, we followed according to a guideline of Australia. So you've got to see them every 3 months. In the first 3 months, you have to do a micronutrition assessment. We're happy to provide you a copy of that. I normally look at the sleeve gastrectomy and I tell them go 6 months, if everything normal. If not, and there is a deterioration in micronutrition, we have to adjust the supplements by the practitioner, the bariatric practitioner, and then we repeat that 3 months after. If not, then you will go 3 months for the first year, 6 months for the next or second year, and then once a year. This one's guidelines, so we've got them all across, and you can visit the website of ANZ MOS, and that will give you a bit of more about Australia and New Zealand of guideline, but we're happy to provide you that as well. We in fact write a letter to the GP and we say this is exactly need to be done. We're very happy with you to do it. There is no issues. My issues is if it's missed. So if you do them, we've got a system. We put the patient, we actually call them, we have to, bariatric registry has to be provided by a good follow-up. And if you don't do the follow-up, you're not on the bariatric registry. We have got a gold follow-up with them because we call them, even the remote ones, and we call them and the problem is missing point. So if you order the test, you've got to make sure you're ordering according to the guidelines. And you make sure that patient, it comes to you and to say, look, I am happy to take your follow-up, but you've got to do it exactly the same what the surgeons do it. And if you don't do it exactly the same, then there's no point because you're going to take him or her, and then I will lose that patient, and then it will be sitting somewhere when there's no follow-up, and then we end with a severe deficiencies later on to be dealt with. So as long as you're happy and you're comfortable to follow that patient and to put them on, we've got a system and it will come with a reminder to this patient, and we send a letter to the patient and GP to say, we've got to do that.
Thank you so much for your answer. Honestly, I'm aware about all this, trust me. Just on a quick, the point is, just one of the patients came to me, again, that was not in Adelaide. I've been in Adelaide only 2 months, by the way. Thank you. That particular cases I'm talking about, they said it's so expensive to go back to the surgeon. It's better to come to the GP. This is the nutrient. This is the letter of discharge letter. Do it and follow it here. And that's exactly what you're talking about right now. Exactly, there's a gap in continuity of care because patient opted, not because I want to do it or I feel comfortable or not comfortable. Is about the patient preference. I have no problem, absolutely no problem. Absolutely no problem. That's not a problem at all. Ordering blood tests and following up, and that's not a problem.
Yeah, look, welcome to Adelaide, but I know that New South Wales is a bit expensive in the follow-up in terms of the surgeons. We've got a very, very cheap follow-up, but we're technically, a lot of people, they don't pay anything because it's bulk billing after the follow-up. And we're happy to see, but I'm talking about a distance. So I do a lot of people from a distance in remote South Australia and remote Australia as well. And I usually talk with them over the phone once 6 months, and the practice bariatric practitioner the same, dietitian the same. But we do ask the local doctor to do all of these tests and to send it to us because we do want to know what is going to happen and what is the replacement.
I'm just going to quickly touch base on that because I deal with vitamins all the time. So exactly what Dr. Chaloob said in terms of actual guidelines, 3 months, 6 months, 12 months, and then annually thereafter. Dr. Chaloob does an additional one at that 18 months as well. In terms of follow-up of our patients, patients aren't charged in their follow-up to see me, and I look after all their vitamins and supplements, so it shouldn't really be a cost barrier associated in terms of turning up. They've just got to turn up, and we do hunt them down reasonably well, but we can't harass them. So if you have any concerns, patients aren't following up, you're not sure, please, and they're our patients, make sure you send them back or give us a call. In terms of patients that are very anxious about certain different kinds of vitamins, knowing roughly what the storage is like on those. So some of the ones we're really, and then putting them on, make sure they're on a proper bariatric multivitamin because you rarely have too many issues in terms of those micronutrients if they're on BN or Fit for Me. But things like B12 will have a 2-year storage. So somebody that constantly wants their B12 checked every 3 months, Medicare is only going to cover it for 1 year. So if you aim for their vitamins to be a bit higher than what is kind of the standard, so B12, sticking them around 400, and it's just easier to go with an intramuscular B12 because of the absorption issues in terms of the oral. So if you know they've had some B12 IM if they need it, but otherwise if you've got one within the last 12 months, they really don't need to be having it any more than that, unless there's a deficiency, like Dr. Chaloob said, in which case you would do it again, 3 months down the track or so to make sure after your initial catch-up as well. In saying that, there's nothing wrong with running them at 3 monthly B12 injections after initial catch-up, at their 12-month blood test, then after that, see what their B12, and if it's sky high through the roof, drop them down. But what I do say to them is you should presume that in time you may get a B12 deficiency again, so make sure you're having your blood test every 12 months. In terms of some other, B6 will be one that you see a lot come up very high on your blood test, and you can almost guarantee that those patients are not taking a proper bariatric multivitamin. They've converted through to an over-the-counter supplement like Centrum or Synovus, which have up to 400 times the amount of recommended daily intake of B6. B6 above 250 can cause peripheral neuropathy long-term. So they've got to get off it, they've got to get back on, and they're really educated on this, but that's where. So if you get a high B6, you can pretty much guarantee they've changed multivitamin, so see what they're on, or they're on a magnesium supplement that tends to have a Mega B component to it. So have a look at what magnesium supplement they're on and get them off that, essentially. Energy drinks is another really big one, and then I've had one recently that was on a probiotic with a lot of B6. A lot of these supplements as well do not have a breakdown of all of what they're in, so have a look at what they're taking over the counter, and you'll usually find the answer in terms of the B6. Vitamin A deficiency is what we don't want, and the only ones I've seen with a vitamin A deficiency are those who do not take a BN multivitamin. If you have any concerns, one of these comes up, we always copy our GPs through to our blood test. Give us a call, particularly for our patients. We treat it aggressively, but it's simple as, Blackmore's 5,000 units, 3 times a day, 3 weeks, continue them on it for the month. That's one we would then recheck in the future. Thiamine deficiencies are usually transient, but we're really aggressive in getting on top of those. So patients where you think they're not taking enough in or vomiting, be really aggressive. Or alcohol, patients that have alcohol, in the future, post-surgery, that you can, at concerning levels, just put them on thiamine straight up. You're not going to overdose them in terms of that, but we do aggressively watch that and monitor that. Iron as well. Don't aim for a bare minimum iron, keep their ferritin up around that 70, 80. They tend to have a lot less hair loss post-surgery as well. They do a lot better in terms of that. So realistic, as long as they keep with their bariatric multivitamin, cost shouldn't be really much of an issue in terms of multivitamin follow-up in terms of at least our clinic. In our bariatric patients, I can't speak for the other ones, but if you get a blood test, you're not sure what to do, we're very happy to be contacted and we can let you know what to do as well with that. The super component to it, ANZ Moss is very closely involved in the government. That was a really big thing, and you're going to be well supported by ANZ Moss signing off where Dr. Chaloob said on a super form. And in terms of the depression component, there's a few key factors we look at. If they've got a psychologist involved, we keep that same psychologist involved because it tends to be a general life issue that they need a bit of extra support with, so we really encourage that. We've also got our bariatric psychologist they can work with. A lot of patients, and we do warn that it takes a long time for the head to catch up with the body, so it does take time to adjust to that new body. Having family support is really critical, and that's actually one of the things we go into, that makes sure there's family support, or they know other people that have had surgery, makes a big difference as well. Adelaide and I and Dr. Chaloob also do a lot of psychological work with the patients as well, not directly asking them specific questions, but actually in the background. Patients are really well supported in terms of, we have a specific app just for our surgery that we developed. And so they have access to that, has a lot of resources, a lot of videos and everything. They get a specific a booklet to follow up with. We don't make complicated rules for them or anything. We're very straightforward, keep it nice and simple to help out.
Before we finish up, I just have a quick question, mostly directed towards Dr. Weeks. You discussed some medications such as naltrexone, bupropion, topiramate. which modulate the brain's reward pathways. And these are commonly used in things like alcohol cessation, smoking cessation, and I think there's trials for methamphetamines and things like that. As such, given the role these reward pathways have in food and eating, do you think food and obesity should be regarded as an addiction and treated as such with things such as CBT and those sort of therapies?
Absolutely. I think for some people, absolutely, food has an addictive pathway, and certainly down patients with binge eating and things like that. And there's a lot of patients that I will do medical therapy with long term. But as I said, on the same side, I always include dietitian involvement and try and either reach out to their own psychologist. I don't necessarily push the bariatric psychologist on all of these patients because I think that their general life has a lot of things that need to be addressed, that if they, certainly when I refer them purely to our bariatric psychologist, they sometimes think that's the only thing to discuss. So I certainly try and get them involved in their own psychologist as well. But look, it's a chronic disease. You've got to look at what's behind it. And one of those factors definitely is the psychological component to it.
Thank you. I would now